Got some good cases this morning for you guys.
We have a punch biopsy. Um, looks, mm,
What part of the body you thinking
oh,
of?
somewhere like the hands or the feet.
Good. Volar skin.
Yeah.
Good. Very good.
Yeah. So it doesn't look like it's like a cancery thing, but it doesn't look like, well, maybe it's like a little inflammatory.
Yeah, good. I think it's probably inflammatory also.
Yeah.
Epidermis is a little acanthotic. Maybe it's been rubbed a little bit, but most of the action appears to be going on down here. And can you tell anything about the pattern?
Yeah, it's diffuse. And it
Good.
looks like there might be like groups of like darker purple cells, like lymphocytes, but it's not like totally dark. So there's probably other cells mixed in there.
Good. Very good. Excellent. What about some of these cells in here that are a little paler?
Yeah, maybe it's like histiocytes or
Good. Very good. So if they kind of look a little bit dark, but they're not jet black, what do you think of the cells might be?
maybe like neutrophils.
Yeah, good. And so what's the pattern of the inflammation that we're kind of looking at here? It is diffuse, but it's not covering everything, is it? It's not like it's
Right?
wiping
Like in
all of it.
groups, like maybe nodular.
A little bit nodular over here.
Yeah.
Got some inflammation here, and then some maybe sparing of some of the collagen. Then maybe it kind of picks up over here again. What kind of pattern do we call that?
Um, like I don't know, dispersed.
Dispersed. It is dispersed, but
Yeah.
when it's
Mitten.
kind of forming inflammation around something, like
Oh,
there's
like
some,
palisading?
yeah, palisaded. Okay, good. And so we have histiocytes, we got some neutrophils, we got a palisaded pattern of inflammatory process. Does that ring any bells?
Mm,
It's kind of an upper level kind of question. You guys are not upper level yet. You're probably more advanced than a lot of your other colleagues at your stage of training.
um,
So remember the three main palisaded granulomatous dermatitis, right?
yeah. Oh, we went over this the other week.
You haven't forgotten it already, have you?
At least I took some notes. Let's see.
Those the three main, just like we talked about the five things that cause, four or five things that most commonly cause spongitic dermatitis, contact nebular dyshydrotic id reaction.
Yeah.
If I say palisaded granulomatous dermatitis, you should just instantly think of three things: GA, rheumatoid nodule, and NLD. So those are just the three things that should quickly pop in your mind whenever we think about palisaded granulomatous dermatitis.
Oh,
Now,
yeah. Okay.
there are some other things that could cause it. So those three don't usually give you this, right? So what kind of cells are we looking at right here? You said it a minute ago.
Neutrophils?
Yeah. So we got palisaded granulomatous dermatitis, but we've got neutrophils in there. So suddenly you say, well, wait, that doesn't fit with any of the three classic ones. GA usually has, mucin, rheumatoid nodules got fibrin, NLD's got degenerated collagen. Well, now we've got polys in here plus palisaded granulomatous dermatitis. And also notice this other thing that's kind of interesting. You see the collagen looks blue like this,
Yeah.
right? We call that basophilia of the collagen. We see that anytime, not every time, but a lot of times we see that when there's a fairly prominent brisk infiltrate of neutrophils that degranulate and it causes the collagen to take on a basophilic as opposed to an eosinophilic color. So that's kind of a helpful clue that you're really dealing with a neutrophilic dermatitis. So this is a little bit of an advanced diagnosis. You may not have heard of it. Anybody on the call have heard of this?
No.
Well, there's a thing called palisaded granulomatous dermatitis with neutrophils. It's basically associated with connective tissue diseases. Palisaded neutrophilic granulomatous dermatitis. And it's often associated with people that have underlying rheumatoid arthritis. It's been seen in Wegener's granulomatosis. If you go back years ago, the so-called Winkelmann granuloma, that's probably really what this was. Sometimes can be seen in lupus. So whenever you see this pattern, you need to step back and ask, does the patient possibly have some underlying connective tissue disease when you see this? So it's just another thing that's in that differential diagnosis of palisaded granulomatous dermatitis. So if you see that pattern and then you see neutrophils, then you say, it's this palisaded granulomatous dermatitis with neutrophils. It's associated with connective tissue diseases. And you need to go back and work the patient up, see if they've got RA or lupus or some other connective tissue disease. So it's a great example of that. It's beautiful. This is what it looks like when you see it. And clinically, they can look they sort of look like GA, although there's a variant that can look like a linear rope in the skin that was reported back in the 1990s. And that's another manifestation of this process. So one other thing here, if you see polys like this in here in abundance, what's in the differential diagnosis that you want to make sure that you don't miss?
Mm. Like an infection?
Good, excellent, infection. So whenever you see like abundant neutrophils, like for example, pyoderma gangrenosum or often sweets or this condition, we'll generally do like a PAS and fight, maybe the clinician cultures it just to make 100% sure that it's not an infectious disease because neutrophils can be associated with that. This, in this case, was negative, so there wasn't any infectious agent. It's a great example of this case. We don't see it very frequently, but it's a good case. They might possibly show you something like that on the board examination. Okay, this is
Dr. Cockerell?
Yes.
Do you mind going back and zooming in on where the palisaded histiocytes are? I couldn't see it very well.
This whole thing up here is palisaded histiocytes in here. All these sort of pale cells, these are histiocytes admixed with the. So these are histiocytes
gotcha.
here. Okay, this is an important one. So this is one that is on the board examination. So it's there. The other one may be not there. This one is there. So you do need to know everything there is to know about this.
I don't know if I've ever done this before, but I can try. So we're looking at this punch biopsy.
Good.
There's hyperkeratosis, looks like orthokeratosis, and some other epidermal changes going on, maybe like some acantholysis or spongiosis.
Good, very good, excellent. Low power, that's great. Very, very good. Okay, what about any inflammation in the dermis?
Yeah, so there's superficial and deep perivascular infiltrate, it looks like.
Yeah, and on a scale of 1 to 10, what are you going to give it?
Tiny, like 2.
Yeah, minimal. It may not really even be inflamed much at all. It's just a very, very sparse infiltrate, if much of anything. Okay, so the main changes are going on up here, as you rightly pointed out at low magnification.
Yeah.
Let's go to higher magnification. And now what do you see?
Well, I mean, sort of more what I saw before. This looks like there's a lot of like within the epidermis, there's acantholysis. That's what it looks like to me. Or I don't know.
What's acantholysis?
Where cells are
lysis?
Cells splitting apart from each other, like the desmosomes being.
Good. Exactly. Very, very good. That's exactly what's going on here. So that's exactly what acantholysis is. Now let's look at this at high. This is high magnification as we go. Are these cells falling apart
falling apart, you mean being acantholytic or something else?
Yeah, is this really acantholytic? In other words, are these cells, have they lost their desmosomes here?
I guess they look vacuolated. Maybe it's
Yes, good. They look like there's something going on inside the individual keratinocytes.
okay.
Got this white color, and then in other areas they've got this pink hyaline almost like color up here. And the neutrophil, the keratinocytes are hyperchromatic up here. Notice here, kind of normal. And then up here, they get more hyperchromatic. And then here you've got this red abnormal cornification going on here.
Okay. Yeah.
And it's prominently hyperkeratotic.
Yep.
Okay. Now we talk about the concept of epidermal reaction patterns, right? What is an epidermal reaction pattern?
Like the different things that can happen within the epidermis, like
Yes,
like
absolutely.
spongiosis.
Good. And yeah, that's it. It's a fairly simple question, but you're right. Yes, spongiosis, ballooning, acantholysis. What are a couple of others?
Third one we talked about.
I think you actually, didn't you present that case at Fort Worth Derm?
Oh, yeah. I mean, I was thinking this looked similar to that. Yeah, what's the word to describe it?
But it's sitting right here. It's telling you what it is. The cells are undergoing lysis, right?
Okay.
Keratinocytes, so it's epidermal lysis, epidermolytic. And then what about this? Hyperkeratotic.
Okay, sure.
Reaction pattern is called epidermolytic hyperkeratosis. Now, I don't like that garbage term that they used in that case report to go epidermolytic ichthyosis or whatever they're trying to call it now. I like this. I like the good old fashioned epidermolytic hyperkeratosis reaction pattern. So this is what this is right here.
Oh, okay.
So fantastic example of this. Now, the board's going to expect you to recognize this. So this is just like you got to recognize spongiosis, you got to recognize ballooning, you got to recognize acantholysis, you got to recognize acantholytic dyskeratosis. You got to recognize all of those. So this is yet another one that's the ABCs of histopathology that the board expects a board-certified dermatologist to recognize histologically. So this is epidermolytic hyperkeratosis. Now, the good news about that is that you can recognize it pretty quickly. And then you've done that part of it. The more sort of not so good news is that they're going to ask you some questions about where you can see this reaction pattern. So that's what they call second order questions. So they pop this on the slide and they say this condition may be seen in which of these following disease states or something like that. So you have to then look down at your multiple choice questions and see which ones are there. So what are some of the things they're going to write in there where you can see this reaction pattern?
Some of the palmoplantar keratoderma.
Good, that's one. It's absolutely one. Yes, you can see it in that. I think some people call that tylosis. And you look at this, interesting, because sometimes you look at people that have palmoplantar keratoderma, it's like the Forrest Gump analogy of, taking a chocolate out of a chocolate box. You really don't really know what you're going to get until you unwrap it. So the same thing is kind of true with palmoplantar keratoderma. Sometimes they just look red and scaly and you biopsy it. And sometimes it shows this. Sometimes it shows syringometaplasia, which is interesting in patients that have hydrotic ectodermal dysplasia. Sometimes it shows psoriasis. Sometimes it shows mycosis fungoides. So they can all look kind of red, scaly, and then you biopsy it and it can show histologically different things. So that is one place you can see it. What are a few others where you can see it?
I don't know if it's in the same category, but that disease that I present on, epidermolytic ichthyosis.
Yeah, and the other old name for that is congenital bullous ichthyosiform erythroderma, because when kids present at birth, because of all this epidermolytic change, they actually get erosions and blisters, and they look red and erythrodermic, and they're oozy, and so it looks bullous in those kiddos. So that's why it was called that originally. I still think it's a good name. And then as they get older, the oozing and sort of erythrodermic kind of morphology goes away, and it gets replaced by this markedly thickened, verrucous, almost porcupine-like excrescences due to this hyperkeratosis, like your patient showed. That's what they get later on. And because bacteria and fungi live in these areas and eat off of that stuff, they get this horrible smell, and it's a horrible disease, really. It's bad when they get that in a widespread fashion. So yeah, that's the other situation where you can see it. It's an autosomal dominant disease, as I recall. What else? Where else can you see it? Not too many others, just a few others.
Yeah, nothing's coming to mind.
Now, the one thing, whenever you get like a widespread ichthyosis or a total body germline mutation, you can have that same process occur post-zygotic, and you get a somatic mutation. So you can get an epidermal nevus, you get linear or systematized epidermolytic hyperkeratosis, and they basically look like they get these weird sort of swirled. If you just look at the individual lesion itself, high magnification, it looks just like your patient that had the widespread ichthyosis, but they get it in the systematized fashion that follow Blaschko's lines, because it's a somatic post-zygotic mutation. So the same mutation that goes on in a germline happens post-zygotic, and it just kind of involves areas where there are Blaschko's lines. So epidermal nevi can give you this histologic finding. Same thing with, what they call linear Derriér's disease. That's the same situation where you get basically post-zygotic mutation that's the same mutation that causes Derriér's disease. And then there's just about one or two other situations.
With the epidermal nevus, is that sort of a misnomer because it's got these sort of changes going on? I think of nevus being like,
no, it's a reasonable
growth of
nevus if you want to. I mean, it's basically epidermal nevi are also post-zygotic mutations as well. They follow Blaschko's line. So it's the same kind of concept. Instead of giving the kind of change you see with the nevus sebaceous or you see with the papillomatous epidermal nevi, you just see this kind of epidermolytic hyperkeratosis change. It's just a different mutation that occurs in the same sort of epidermal nevoid morphology.
All right.
There's just a couple more. You may not know them. You can get these things as solitary keratoses. So somebody comes in with just one of these, you take a biopsy and it shows this change. You say, wow, what's that doing there? And that's probably just a sporadic mutation. It occurs just in one little lesion. And then these things can be disseminated. You disseminate epidermolytic acanthomas, and they can be widespread papules. They look like warts and whatnot, but they're not. So they show this. And I don't recall the exact gene mutation here. I think it's a keratin gene mutation, but you need to know the mutation that's associated with this, and you need to know the inheritance of it. So that's a good example of epidermolytic hyperkeratosis, and it's an epidermal reaction pattern, and you will confront that on the board. So it's kind of good news, bad news. Good news is you know what to expect because it's coming. Winter is coming. Well, that's coming.
Oh, Dr. Cockerell, sorry, one more question about that one. So those islands of like cells within the epidermis, is that just because of how it was cut, or what cells are those?
No, these are all keratinocytes here. Every single one of these pale cells, keratinocytes, and it's papillomatous and hyperkeratosis. Now, this is cut perfectly at 90 degrees. It's a great cut. Beautiful example. So all this stuff here is the pathology. That's real, honest to goodness lysis of the dermis with hyperkeratosis and trichohyalin granule-like changes here. This is pathognomonic for that process.
Okay.
All right.
Okay.
This one's coming too, most likely.
So this looks like a shave. It looks neoplastic.
Good.
I see a lot of cysts.
Good. You do see a lot of little cysts. I totally agree with that. So you think it's
And
benign, obviously, right?
yes, I think it's benign.
Yeah, it's pretty small, well circumscribed, vertically oriented. And you think it's an epithelial or a non-epithelial neoplasm, or maybe both?
Um, I think it's epithelial.
It's definitely epithelial, at least in part, right? You said cysts. Cysts
Mm-hmm.
are epithelial lined, so that means
Mm-hmm.
you've got epithelium somewhere there, basically. And then you see these little small aggregations here that look like epithelium. But what about all this stuff in the middle between the epithelial islands here?
I thought that was inflammation.
There's not a whole lot of inflammation, but there's certainly this prominent fibrotic stroma here. And notice that it's not fibromucinous. Now, a little bit around here, there may be a little bit of fibromucinous change, but most of this is kind of thick fibrotic collagen. And we see that quite commonly in the adnexal neoplasms, like trichotillomanias and those kind of things you get. So these adnexal neoplasms, when they have, they often have both a stromal component and an epithelial component. It's like a seed and soil kind of thing. You kind of need both. It's like an Nevus sebaceous or some of these epidermal nevi. If you go in and just shave them off or dermabrade them or whatever, think that you're going to cure the patient of it, you're not going to, because they've got this non-epithelial component that sort of feeds it. So this is all part and parcel of the lesion here. The fact you've got the stroma and the epithelial components. And it's benign. Okay, so let's go to higher magnification and see what kind of differentiation we're looking at here. So what kind of differentiation is this where you see these little cysts like this? Let's just say we
Maybe
saw,
echo.
well, sometimes, but rarely. So let's say we just saw this and we didn't see anything else. What would be the diagnosis here? And you said it already.
Oh, like a cyst.
Yeah, a cyst. It'd be like an infundibular cyst. Okay, and at
Mm-hmm.
the infundibular part of the infundibulum is where? What part of where's that in the body?
A hair follicle.
Hair follicle, upper part of the hair follicle. So when we
Mm-hmm.
see cysts like that, you say, well, that's a sign that there's probably at least a component of it that's follicular. Now, when you think about hair follicles and you think about how they come about in the embryo, where do they form in the embryo?
Mm-hmm.
Just think about a little miniature hair follicle in your little baby that you just had not too long ago. If you went inside there when they were still in gestation and you looked at their hair follicles they were forming, where would they be forming? There's a special place that leads to the formation of hair follicles. Like it's kind of right in this area. So we have the infundibulum, we have the isthmus,
Mm-hmm.
we have the inferior portion, and in that little zone in the isthmus is what we call the mantle zone, and that's where the stem cells live. In that area, they're primitive stem cells or germinative stem cells. Some of those cells can form hair follicles. Some of those cells can form apocrine glands. Some of those cells can form sebaceous glands. So if you look at this lesion, here's a primitive hair follicle right here, right? There's the outer root sheath. There's a little small hair shaft that's formed. Here's a little apocrine gland. It's got a little decapitation secretion there. And then over here is a little sebaceous, possibly gland here and there. So it's a nice example of where you got the mantle zone that's kind of forming this little hamartoma with this prominent stroma surrounding it. So we've got a hamartoma that's got apocrine and follicular, and maybe in a couple of areas, possibly a little sebaceous lesion. So this probably doesn't have an exact name to it. Here's sebaceous over here. So basically, we call it something like a mantelloma, if you will. It's got components of an apocrine adenoma, apocrine hygrosystoma over here. It's got areas that look like a little primitive, possibly part of a trichoepithelioma. You got little papillary mesenchymal bodies over here. And then you've got the prominent stroma, and you've got the little cysts. So it's just a nice example of a benign adnexal neoplasm that's differentiated along multiple different lines. Okay, it's not just along the lines of one or the other. But if you see this, you know that it's infundibulum. And so just remember that little mantle zone where these things develop. Could get this on the board. What are a couple of other follicular hamartomas that can kind of look a little bit like this little area right here, where you get prominent stroma, these little strands of residual follicular epithelium over here that can be associated with renal carcinoma, renal cell carcinoma, and also emphysema, blebs in the lung that rupture. And they get multiple papules in their body, in their face. Anybody know? Okay, well, you'll know now. Birdhog-Dubé. Birdhog-Dubé. And those give you they get trichodiscomas, perifollicular fibromas associated with those lesions. And then something like that would be like a little perifollicular fibroma. They look like this. They get this prominent stroma surrounding these little small strands of follicular epithelium. And they're also mantle zone lesions where they form. Okay, any questions about that one? To give this one a go. This could easily be on the board exam too. If I were writing the board, I'd probably stick something like this on there.
Marissa, did you want to take this one?
Is anyone else on here that hasn't gone yet?
I think it's just us, you guys.
All right. Okay, so we got a punch biopsy, and it looks like it could be like a double punch because there's these extra pieces here at the bottom or on the right. It looked like
okay, that's a good observation. I'll tell you what they did here. Yeah, okay, double punch. What's the orientation of this one over here?
oh, it's like sliced differently, maybe.
Yeah, yes, it is sliced differently. How? How's this sliced over here versus this one?
Like
You guys don't remember
maybe it's like how the Moes do it the other direction.
Oh, sort of. Yeah, you guys probably don't remember the old John Belushi Saturday Night Live skit where he was the samurai guy that was opening beer cans with his samurai sword and stuff like that.
Oh, okay.
Chopped it this way, and then he chopped it this way, So this one's the vertical section, like we take a regular punch biopsy, and this they cut horizontally here. So you get one that's cut, looks like a cylinder, and the other one is cut, like this in this direction. And the reason for that is that you can see more hair follicles here. So this was actually published back in the 1980s. Dr. Terence Headington wrote this up, and he said, this is good, but this is better if you cut it in the right way because you can see more hair follicles. It's kind of interesting. So yeah, so we generally do both a vertical and horizontal section when we're looking at alopecias. So that's why it's sort of a double punch. Now, if you read the literature, they say, we'll take 1 6-millimeter punch and then try to bisect it and send the bisected part to the lab and the regular and the non-bisected part, and tell them to do one horizontal and one vertical. It's really hard to do that because if you try to cut a punch biopsy on a Mayo stand, it's sort of like trying to cut warm rubber. It's not easy to do. It's better just to take 2 3-millimeter punch biopsies and say, this one do horizontal, this one do vertical. And the lab should do that. And if you do, you can get 2 different pieces to look at, and you may see a relatively few number of follicles that are affected here, and you may see several follicles that are affected over here. So it just gives you more of a sample is really all it does.
Okay. So
tells you an alopecia. So I've given you a lot of
Yeah,
Hence,
now we know we're dealing with an alopecia. Um, I mean, it looks like if for being alopecia, there's a good amount of hair there.
yeah, okay, good. So what does that tell you that they probably look like clinically? Now we
Um,
see hairs there. In what stage of hairs are these in right here? So you're right. They're normally, if you do a biopsy of normal hair, if I biopsied your scalp, we'd see about 8 to 10 wonderful anagen follicles living down near the subcutaneous fat. 8 to 10 on a vertical section, horizontal section, just like this. What about here? Do we see that many? We see a lot of hair follicles in here, but are they all in anagen?
but they're all in different phases.
Good. They are in all different phases. Yeah. Yeah. And so you got some that are, looks like this one's maybe in catagen that's shifted towards catagen here. We've got a telogen follicle up here. Things are willy-nilly, but what do you think their scalp is going to look like, given that they have some follicles still sitting in here in anagen?
Right. Probably doesn't look like they have hair as much because they're not all in the growth.
Right. They're going to have less hair, but they're probably not going to be a shiny, totally patch devoid of hairs, right?
Right, right.
Some hair shafts there. So if you look at their overall scalp, it may be kind of moth-eaten. It may be kind of patchy alopecia. It's not going to look like alopecia universalis, for
Right.
example. Okay, good. So when you're evaluating alopecia, what's your approach? How do you do that?
Let's see what phase that they're in.
Well, you can do that.
Yeah,
That's one
part of it.
nice general kind of approach when you're going through it. So you say, well, what I like to do is say, well, let's take a look at it and see, is it inflammatory or non-inflammatory? You know, how much inflammation do we see? If there's inflammation, where is the inflammation? Is it up here around the infundibulum and isthmus part? Is it down at the bulb of the follicle? Is it localized to the follicle, or is it diffuse, wiping everything out? Okay, so that's basically initially. So if we see if it's inflammatory or non-inflammatory, then we ask ourselves, well, do you think it's permanent or non-permanent? Permanent with scarring or permanent without scarring? And we kind of maybe move the needle a little bit from permanent alopecia. You know, we think of androgenetic alopecia as being, quote, permanent. Well, now that we've got platelet-rich plasma, we got minoxidil, we got all sorts of therapies, maybe that's not so permanent. We used to think alopecia universalis was permanent. Well, we now have JAK inhibitors, so no, that's no longer permanent. If you get scarring with inflammatory changes in the hair follicles, those become permanent. So those can be, they ain't ever coming back, you know, when there's scar there. So that's not going to come back. So based on that, where would you classify this alopecia? Inflammatory or not inflammatory?
Not inflammatory.
Yeah, we don't really see much inflammation here. So that wipes out a lot of diseases, right?
Right.
Takes a lot of things out of the picture. Now, what non-inflammatory alopecia do you know that gives you follicles in lots of different stages of evolution, gives you maybe some possible fibroplasia around here? There's a crack between this hair follicle here and the perifollicular stroma over here. We've got this finding here, which is pathognomonic of this diagnosis here. So what am I pointing out here?
The isthmus?
What's this? What's this thing I'm pointing to?
Like that part, is that the part of the hair shaft?
That's the hair shaft. Now, does that look normal to you?
No, it looks kind of dark.
Yes, that is extremely dark here. This might be their normal hair color, but this is not normal here. That's basically a hair shaft that's been damaged, twisted, and the melanin is clumped there. And there's a special term for this process here.
Oh, it's a term. Like they're pulling it out on their own.
Yes, they are. They're probably both pulling it. What they do in these cases, these patients that have this disease generally like to twist a lot, you know, or if they're neurotic, you know, usually schoolgirls, that kind of age group, they start chewing on their hair and twisting it and that sort of thing if they're nervous in school or whatnot. So basically, this is called trichomalacia. Tricho, hair, malacia means softening. So it basically means that the hair shaft gets damaged and it forms these puddles of melanin and it's a destroyed hair shaft. That's pathognomonic of trauma. Here's another area where you basically, there's no hair shaft even in here anymore. They probably yanked that one out. And that we showed before. So look at this. This is all damaged, twisted, destroyed. And then you've got catagen. Whenever you see necrotic dyskeratotic keratinocytes in a hair follicular epithelium, that means the follicles is in catagen. So that's been shifted into catagen because of trauma. So what's the diagnosis here?
Trichotillomania.
Yeah, trichotillomania. Good. Classic. Pathognomonic of it. Pathognomonic. Now, the one thing that we sometimes see, interestingly enough, is patients that have alopecia areata, and this is not AA because there's no peribulbar inflammation. You know, it doesn't have any features of AA. This is just perfect for trichotillomania. Sometimes we'll see alopecia areata, and then we see secondary changes like this because the patients start saying, hey, my hair's falling out. And they reach up there and they start twisting it and pulling it themselves. And the next thing you know, they've got trichotillomania superimposed on their alopecia areata. Because they say, wait a minute, what's going on? And they start helping it out. So that's what happens in that situation. It isn't, you normally shouldn't get trichomalacia in alopecia areata, but the patients actually do it on their own. Now what's the difference between traction alopecia and trichotillomania? That's more of a difficult question. Probably for more of a second or third year resident, but maybe you know the answer.
Like for pathology or like in clinically?
Both.
Okay, well, clinically, the traction, it's like with a hairstyle. It's not like they're intentionally pulling out their hair. It's just being like pulled back.
Yeah, they're basically that's almost, I like to think of it as more kind of slow death. You're like putting cornrows in your hair or you're pulling it back, whatever, and what you do over the course of time is you just cause ischemic necrosis of the hair follicle, and it turns the perifollicular stroma, becomes like this onion skin scarring that eventually just kind of gradually strangulates and replaces the hair follicle. So that's what happens with chronic traction alopecia. And actually, there's an article that Leonard Sperling just published, I think, in the American, maybe a JAD. But anyway, they talked about the fact that you get fewer follicular units also. So in other words, normally you'll see like a sebaceous gland with 2 or 3 follicles surrounding it, like right here. Well, there you'll see a sebaceous gland with maybe 1 follicle. And eventually you don't have as many follicular units because they've all been strangled away in that situation.
So they all like die out from ischemia.
They basically, think of it as like killing somebody by hanging them with a piano wire, as opposed to this disease where you basically stick a noose on them and you knock the chair out from under them. So this is more fast death to the hair follicles. Traction is more chronic death of the hair follicles. And usually get more perifollicular fibrosis in that condition than you get in trichotillomania. Trichotillomania, they're just pulling and twisting their hairs and they're just destroying them, and they get all these follicles in different stages of evolution. It just, they're saying, wow, you've killed me here. And this will regrow if they quit doing it. Traction often doesn't regrow because it basically turns the hair follicles into scars. If you do this enough, you can cause some scarring. But if you basically just do it for a relatively short period of time and then you put them on some medication, they quit doing it, well, then it grows back. So this is generally a non-permanent alopecia, whereas chronic traction alopecia, we really don't like people to do those kind of things long term because that basically leads to permanent alopecia, more scarring. Okay. This one's coming too on the board. It's a
So
gift.
if I don't get it wrong. Okay. So this looks like a shave biopsy of a papule.
Good.
It looks neoplastic. There's some basaloid cells, a lot of
Good.
them, and then some stroma intermixed between. Also, these big vacuolated spaces as well.
Okay. I think that may be part of it. Some of that's artifact over here.
Okay.
So what do you think, benign or malignant?
This looks benign to me.
Okay, reason?
It looks relatively well circumscribed. I can kind of see the whole thing. It's not terribly asymmetric.
Good.
I mean, it maybe is, I don't know exactly how big this is. It doesn't look huge though.
Good. So low magnification, strongly favor benign. What kind of differentiation?
Well, looks basaloid, so um could be, either like squamous or some sort of adnexal structure.
Okay, good. So basaloid, epithelial, maybe adnexal. We're going to go to higher magnification, see if we can then tell. So good. We're exactly where we should be at that power. Let's go to higher magnification. And now, what do you see? This is also one of those, got to kind of put it in, imprint it in your brain so you can recognize it.
There's a lot of blue cells here.
Good.
It looks like they had some spines on them, if I'm not mistaken. I don't know if that's what that.
Yeah, there's definitely some intercellular bridges. They're a little bit expanded here.
Okay.
Other area. What about if you just look at the individual cells themselves? Describe those cells.
Well, they have dark blue nucleus. There's, a relatively like high nucleus to cytoplasm ratio. I don't see a lot of pleomorphism.
Good. I agree. So no cytologic features that make us think it's malignant.
Right.
What about if you kind of look at one compared to another, what would you say about that?
How some are darker and some are lighter in color, maybe.
A little bit, but do they look pretty similar?
Um, in general, I mean, I thought so, yeah.
Yeah, they do. They look almost like clones. These look almost like identical twins. They really look very, very similar, homogeneous morphology to these cells. And what cells give you these dark, small, cuboidal, basophilic cells with a high nuclear cytoplasmic ratio, and some cells that have maybe a little bit of glycogen in their cytoplasm over here, some of these clearer cells? What type of cell gives you that? We know we're dealing with epithelial. So what kind of epithelium is associated with these small, cuboidal, basophilic cells like this?
Well, I mean, Eccrine.
Yes. 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 Very good. Eccrine. Okay. Now this is where it gets a little bit more advanced, but you're adding this to your encyclopedia. So what kind of differentiation, what kind of eccrine differentiation gives you sheets of these small cuboidal cells that all look alike, pretty much? What do we call that?
Well differentiated.
Well, it is well differentiated, but it has a specific name for the type of differentiation that we're looking at right here. There's a specific name for it. Sometimes things are named after like a disease state, like psoriasiform named after psoriasis, lichenoid named after lichen planus. Sometimes this is the type of differentiation that's named after probably the entity, but it actually is, it's kind of a weird name that was originally described. So you don't know. That's okay if you don't know. You will know.
Yeah, I can't
Anybody know? It's called poroid differentiation. Poroid. And when you think of that, you think of there's about 4 diseases that can give you poroid differentiation. So the number one is this diagnosis. You have any idea what the diagnosis is by chance? It's eccrine.
Mm-hmm.
differentiation. Any clue as to what the actual diagnosis is? Here's a duct.
Well, I can tell you what it's not, but I don't know exactly what it is. Maybe, yeah, never mind. I don't know.
Okay. Anybody know? This is Eccrine Poroma. Poroma. Eccrine Poroma. Most common location is on the acral sites, like the sole, palm, but they can occur anywhere in the body. I don't think this actually was on palm or sole here. You see the ductal differentiation goes along with that eccrine differentiation. And this is what's called poroid differentiation. It's seen in this condition, Eccrine Poroma. It's also seen in hydroacanthoma simplex, which is kind of like a poroma in situ, if you will. Then there's a thing called the dermal duct tumor, where you see the same kind of poroid differentiation, but there's no contiguity with the epidermis. And then the last one is a poroid hidradenoma. And then you can get malignant lesions of this differentiation. So this is poroid differentiation. I guess the guy that originally called it poroma thought it was like the pore of an eccrine unit. So that's why they called it poroma. So anyway, but when you talk about poroid differentiation, you think that it kind of has this very, very monotonous, attack of the clones morphology. All these cells are small, cuboidal, basophilic. They all look just exactly like one another. Sometimes you can actually see areas of necrosis en masse in these lesions, and that's kind of an exception to the rule of where you get necrosis en masse being a sign of malignancy, because it commonly occurs in these poroid lesions. So eccrine poroma. See, that's contiguous with the epidermis, like this.
Yeah, it just sort of blends right into it.
Yeah, it does. And you can see here's the epidermis, normal stratified squamous epithelium, and then boom, here you've got the poroid cells that forming the lesion just underneath it. This dilated blood vessels are quite common. If you look carefully, you'll usually see a couple of areas. There may be some ductal differentiation in the lesion, like over here. So, and this may be one like a little cystic area within it also. All right, so that's poroma. So now you know that differential. Look at this one. This one's a little funky, but we can.
Okay, so we have punch.
Okay.
It looks inflammatory.
Good. Are you going to be able to come up with a specific diagnosis based on this?
Maybe I should be, but I don't think at the
I'm going to
moment.
say probably not. I probably couldn't. Just looking at this power, I can come up with a differential diagnosis, but the chances are not the world's best that we're going to be able to come up with something specific like the last case. The last one you look at it, say, that's Eccrine Poroma, move on, next case. This one we're going to have to work through. We're going to have some information to help us here. We're going to have to look at a lot of ancillary things. We're going to come up with a differential diagnosis on something like this. So this isn't just pathognomonic looking at it at low power. But we can do what you're doing, is talk about what we're seeing and what's the pattern of inflammation. We're going to higher magnification and see if there's any change in the epidermis that might help us. We're going to look at the dermis, see if there's maybe some deposits of material or something like that. If we're going to do all those things, then we can come up with a differential. But you see that's you should be able to size it up almost like handicapping a horse at a horse race. When you sort of see something like this, you say, well, I know I'm not going to be able to come up with an instantaneous diagnosis here unless I see something in the epidermis or somewhere else that's pathognomonic. So what do you see?
I see perivascular inflammation.
Good. What kind of cells?
It's lymphocytes around the.
Good. Very good. Superficial, mid, perivascular infiltrative lymphocytes. This is just coincidental trauma from the procedure. Okay.
Oh, okay.
Let's look at the epidermis. And let's see if there's anything else we can see in here. So what do you see in the epidermis? What do you not see?
I don't see um hmm,
We see any spongiosis?
no.
No, not much. I
I mean,
agree. Do we see an interface change?
no.
No, we really don't. Do we see any acantholysis? Do we see any epidermolytic hyperkeratosis? Do we see any of those kind of changes?
No.
No, we don't. We don't really see very much going on in the epidermis. There may be a few necrotic keratinocytes here and there, maybe a few of those, but it's pretty nonspecific. So this is mostly dermal inflammation. And let's take a look.
Hmm.
These are lymphocytes, so that we didn't get fooled at low magnification. Well, I don't see any eosinophils. This is more solar elastosis, so I really don't see too much in the way of mucin here. So can we make a specific diagnosis of this?
No.
No. So if they sent this into us as rash, we wouldn't be very happy, would we?
Not at all.
No. But based on this, what is your differential that you think about here when you see this mostly perivascular lymphocytic infiltrate without a lot of epidermal changes? And there's a little bit of a deep involvement here. So just what are a few things that you're going to think about? And then you're going to look over at the pathology rec slip, and they're not going to be someone that just put rash unspecified. They're going to give you something that they think clinically, and then you're going to say, ah, yes, it could be that.
When I think about prevascular inflammation, um, those L's
Mostly
come to
lymphocytes.
mind.
Good, the 5 Ls. Now, this doesn't have the deep infiltrate, but anytime you get
Yeah.
any of those superficial deep infiltrates, sometimes they can be only superficial also. So I would agree, you'd put those 5 Ls in the differential diagnosis. Now, which of those do you kind of like the best here, since there's no mucin, there's not much epidermal involvement, maybe there's a couple of dyskeratotic keratinocytes?
Um, Maybe like a polymorphous light eruption.
Good. Yes, a photodermatitis. It could be a variant of polymorphous light eruption. Now, the classic polymorphous light eruption is superficial and deep with papillodermal edema. We don't really see that here. But we thought it's sent into us as the person it was in a photo-distributed area. They thought it was worse from the sun and that sort of thing. So we signed this out as consistent with some type of a photodermatitis. Usually, if we're a phototoxic dermatitis, we'd like to see more epidermal involvement. We'd like to see some dyskeratotic keratinocytes. We don't see that many of those here. So it might be that. Maybe they were taking a medication and got worse in the sun. So yeah, that absolutely could be what this could be, given this pattern. But we wouldn't know unless we had good clinical correlation with something like this. What's the most common drug to give you a photodermatitis?
Um,
Lots and lots of people take it for high blood pressure.
oh,
Hydrochlorothiazide.
Yes,
yes.
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 Usually that gives you more of a lichenoid infiltrate or spongiotic drug eruption, photodermatitis. But yeah, that's probably the most common one because gazillions of people take that. All right, let's do one more.
All
Let's
right.
do this real quick and we'll get to clinic.
Okay, so we got a shave biopsy. Uh, looks like it's not totally inflammatory, but there's some darker cells in there, towards the right, especially. So maybe it's neoplastic
Good.
too. Yeah.
You know what kind of cells these are?
Uh, they look similar to that blood vessel right there. Look around that. Is that a blood vessel?
No, I don't see blood vessels here.
Oh, so
But
maybe
no
not.
pigment up here.
Oh, that
Pigment.
does look pretty Like there's a pigment in there, like a hemosiderin or a melanin.
Melanin.
Yeah.
Good. Melanin here too. So what's the diagnosis of this part?
Epithelial?
Well, it's a special type of epithelium. It's arranged in nests with melanin. It's not this kind of epithelium.
Yeah. It'd be like some kind of a gland.
Well, there's no real glandular differentiation. It's
Oh.
arranged in nests.
Oh.
So what's the most
Hair
common lesion?
follicle?
Well, there's a hair follicle. This doesn't look like that. It's got melanin. What cells have melanin?
Melanosomes?
Melanosomes carry the melanin, but what cells have melanin?
Oh, keratinocytes.
Well, they get the melanin injected into them from the cells that make the melanin.
Okay.
What cells make melanin?
Melanophage.
Melanophage eat melanin.
Eat that. It's too early.
You're close.
What?
You're close. What cells make melanin? What's the Greek word for cell?
Greek word for cell. Site? Oh,
Yeah.
melanocyte. Melanocyte.
Right. Okay.
Wow, how did I not have that word in my head? Okay.
Yeah. So what kind of lesion is this part over here? It's a benign
Melanocyte.
neoplasm with melanocytes. And what do we call that?
Benign neoplasm. Melanocytoma? I don't know.
Well, we don't like that term very much. But what's the most common benign melanocytic lesion that you've got? Everybody's got on their body.
Oh, like a lentico or a nevus?
Nevus, melanocytic nevus, mole.
Oh, that's it.
Yeah, that's it.
Oh,
What's going on over here?
okay. Those look different. So these are
Okay.
kind of like a foamy light grayish material inside.
Yeah. How do we add that up with the nevus here? And the cells are like contiguous with the nevus.
Maybe it's like some kind of specialized nevus.
Yeah.
Oh, like nevus sebaceous.
Well, these aren't sebaceous cells, though. They don't have those little nuclei with little strands of. Here's sebaceous.
Yeah,
Nice example.
more
See
sebaceous.
that? Look at that. Sebaceous cell. These cells. They're not the same. They're different.
Okay. What else can this be? Another kind of specialized nevus.
This is specialized nevus. Any idea what kind of specialized nevus?
No.
Anybody know?
Call a friend. Call a colleague.
Call a colleague. Any colleague know? You're looking at it right here. You're never going to forget it. Balloon cell nevus. Balloon.
Oh, they kind of look like balloons.
These look like little balloons. Yeah. Balloon cell nevus. There's a bunch of different types of nevus cells. It's another mantra that Dr. Ackerman used to teach us. Large cell, small cell, pagetoid, balloon, oval, spindle, multinucleate, dendritic. It's pretty much all the different types of melanocytes that you can see. So these are balloon cell nevus cells here, admixed with small round cells. Okay? Balloon cell nevus. One of the 8 types of melanocytes that can cause a benign nevus. All right. We'll stop there.